My name is Lisa Callahan. I'm a Senior Research Associate at PRA, which is the home of the SAMHSA Gain Center.
My name is Shannon Bader. I am a Senior Project Associate at PRA, which is also part of the SAMHSA Gain Center. And I first became connected with the SAMHSA Gain Center when I was working in New Hampshire at the Office of the Forensic Examiner. And I was part of a learning collaborative that was put on by the Gain Center to help forward competency restoration in various states. Lisa, do you want to talk about how the Gain Center has really helped all these states through learning collaboratives and policy academies?
Sure. So about 5 years ago, SAMHSA asked the Gain Center to begin some work on competence to stand trial. So that led to SAMHSA funding us to host a learning collaborative. And in the first year, we put out a national solicitation. We had a number of states respond. We selected 8 states to participate. And what we learned also in that learning collaborative was states were really struggling with this topic. So SAMHSA funded it for a second year, which is when New Hampshire became part of the learning collaborative. And actually, we continued that learning collaborative for 4 years. And we worked with 14 different jurisdictions over that period of time. We also hosted a policy academy last year with 5 of the states that had participated in the learning collaborative. And we're going to have another learning, policy academy in the spring of 2024. So SAMHSA has really been out in front of leading this work, not just making recommendations, but finding out what states are doing, what their needs were. We provide a lot of TA, technical assistance, to the states, and have really, I think, really moved the field forward in that states are able to share across the states. We're able to see where the major gaps are, where more work needs to be done. And it's been really gratifying work for me personally, but also for the Gain Center.
I think that the Gain Center has been really instrumental in fact, bringing all those states together. I can say that when I was working in New Hampshire, it was really difficult because our state leadership at all levels didn't really realize that our state was struggling with the same issues that every other state was. They thought it was an internal problem. They thought it was something that just needed to be fixed in-house. And once we were able to share, hey, this is the information we're getting from SAMHSA, this is the national scan, look at all these other states with these same problems, then there was a better sense of wanting to figure out solutions instead of just pointing blame. So once the person is evaluated, there's an evaluator who makes a decision about whether or not they are currently competent to stand trial or if they're not currently competent to stand trial. If they're currently competent, they just proceed on with their case and they can follow the criminal legal systems process from there. If they're not currently competent, the evaluator then has to make a decision about whether or not they are restorable or not restorable. Folks who are restorable tend to have mental health conditions, usually psychosis of some kind, and will benefit from some sort of psychiatric treatment. Medication, we know, is an important piece of restoration for competency treatment. So most of the time, the system has been that those folks were then referred to the state forensic hospital. However, as the numbers increased, those beds didn't increase. And in fact, most states have seen a decrease in the number of beds they have available for inpatient psychiatric care. So as those numbers sort of mismatched, we have this problem with folks waiting a very long time to get the inpatient mental health care that they've been ordered to by the court system. So once folks get into the inpatient setting, then it's actually a relatively quick process. The data shows that generally folks get restored in an inpatient setting within 6-8 months generally, sometimes even faster. And then they can return to court after they've been evaluated or the judge has once again said that they're ready to go back. And inpatient settings tend to be really good places for folks who need that level of care. So the nurses, the daily day staff, the psychiatrists are all very used to seeing that level of acuity. They're used to seeing these symptoms. They know how well someone has to be to go back to court. Then they're able to quickly determine what their needs are, make a treatment plan, and treat the person. The issue comes when there's just too many people, not enough beds, and not enough staff to provide that level of treatment across the country.
Yeah, and I think that's something that we've found all along the way is maybe what drove the states to even participate in the Learning Collaborative initially is that wait list.
Yes.
Because most people who are on the wait list, as we know, wait in jail.
Yes.
And jails are not a place for people with psychosis. No matter how much treatment is available, no matter if they have a special pod for people with severe psychiatric illness, the fact is it still is an incarceration setting, and it's a stressful setting, it's noisy, often don't have the services available. It's really important how you describe the system, because you name so many people, starting with the judge, who someone has raised, probably the defense attorney, has said, I can't, my client isn't really able to comprehend what's going on here, I need to have a competency evaluation done. Judge says fine. Well, then it becomes the mental health system's problem. Mm-hmm. But it's the legal system, mental health system, always trying to negotiate this, how many people should be going into the system, whether they need to, whether they need that level of care that the hospital provides, which I think we would all agree is the most intensive, most expensive system. That's something that really blew me away, is how expensive inpatient restoration is. It's over $1,000 a day.
Yes.
In most jurisdictions. So this movement, and this is really something we've seen, and I would say there's a greater interest in more outpatient restoration, and outpatient not meaning in jail, but literally outpatient programs for people who don't need that level of, they don't need that level of security, they don't need that level of care, they need to get connected to services so they can return to the criminal justice process and have their cases dispensed with.
And I think it's really helpful to remember that when we talk about inpatient settings, we're talking about locked doors, usually razor wire, 24-hour nursing care, 24-hour access to all kinds of treatments. And these are really secure, intense settings. And when you say expensive, you're right, $1,000 a day. We often talk about how one treatment for restoration is almost sometimes the same price as a year at Harvard. And so that cost is really cumulative over time for counties and states. And that's a lot of money to be spent on maybe someone who doesn't necessarily need 24-hour level of service, locked doors, and razor wire. There are a lot of folks in the system who don't need that level of care.
And one of the things that we found also in talking with states, especially early on, is that they wanted to move people charged with less serious offenses out of the process altogether, because what they need in most cases is just to be reconnected with services in the community, housing, transportation, therapy, medication, etc. And they'd somehow gotten severed from whatever level of care they'd had in the community before. And it may have been periodic incarcerations, mm-hmm. because one of the things that we found also is that, and I think this isn't just true of the competence population, but every time they go into jail, their medications changed. Mm-hmm. Every time they went into jail, they lost contact with their case manager. Every time they went into jail, they lost housing. And so for this population that has a very high level of psychosis, but a relatively low need from a security standpoint, end up with really a very fragmented level of care in the community. They can't sustain them in a way that's healthy.
And I think that's just it, is that the numbers have increased so dramatically over the last decade or two that the pattern has always been an order to inpatient care. So that creativity, that connection, those networks, again, between the judicial system and the mental health system that may not exist, have to be formed for there to be change. That the jail is at the county, the judicial system is completely separate in all ways. Their office building is in a different building. Their meetings are separate. The county is their own jail system, and then the state hospitals are at the state level too. None of those silos have any connection to each other except at the competency system. These are folks making decisions about the same defendant who've never met each other, who don't know each other at all. How can they make a thoughtful decision when they're all looking at just this small view from their seat? And that's really what the learning collaboratives have done. That's what the policy academies have done from the Gaines Center, is ask these systems to come together, meet together at the table, figure out what is our common goal, how can we move our whole decision process forward so that the defendants, the people, the mentally ill folks who are stuck in jail waiting months sometimes to get placed where they didn't even need to be placed at that level of care in the state hospital, that can be fixed for those folks.
Mm-hmm. Yeah, one of the things I think that's really impressive in the sense of when you put all of this together, all of this work that the Gain Center's done, and we have that in a report that we recently was published on the SAMHSA store, which covers findings from the Learning Collaborative, certainly a finding of all the research and update of all the research that's been done on competence to stand trial, what the states have been able to accomplish, and what's left undone. It is a work in progress. It is really a number of states made legislative changes over the last 5 years. Some have, interestingly to me, in some cases they prohibited outpatient restoration. And in some cases they were silent on it. Their legislation was silent. Yeah. Some states now have specifically built it into their legislation that it should be an option. And a couple of states actually say it should be the first option. The American Bar Association also recommends that diversion should be the first option for people with mental illness.